Hello, I'm Cassandra Muir, a clinical research coordinator at the Children's Hospital of Philadelphia, working on the biologic abatement and capturing kids' outcomes and flare frequency in juvenile spondyloarthritis trial, also known as BACK-OFF JSpA. The premise behind this study is that many children with juvenile SPA achieve remission on tumor necrosis factor inhibitors, which are costly, given via subcutaneous injection or IV, which is oftentimes not desired by children and adolescents. And these medications have a long list of side effects. Many patients, families, and providers want to know if TNFi therapy can be tapered or stopped without flaring patients' underlying disease. Currently, there are gaps in evidence that hinder rheumatologists' ability to provide data-driven answers to families. Standard practice is to begin TNFi de-escalation once in remission for 18 to 24 months. However, there is a lack of data supporting this practice. Currently, the BACK-OFF JSpA trial is enrolling patients who are on a standard dose of TNFi who have been in a clinical remission for a minimum of 6 months. Patients will be stratified by their history of axial disease, specifically history of sacroiliitis upon MRI imaging, and by polyarticular disease course. Patients will be randomly assigned to one of 3 treatment arms. Arm 1, continue TNFi at a standard dose. Arm 2, taper TNFi to a fixed longer dosing interval. Or Arm 3, stop TNFi. Patients will have visits every 3 months during the active intervention period, lasting 12 months or until time of flare. Physical exams and patient-reported outcomes will be collected at each visit. Study outcomes will compare the likelihood of flare and patient-lived experiences between the 3 treatment arms. Post-intervention, patients will be observed for up to 24 months for long-term monitoring of disease activity, measuring time and ease of recapturing disease inactivity. The BACK-OFF JSpA trial hopes to bridge the gap in knowledge and create more informed physician-patient caregiver conversations about options for patients in a clinically inactive disease state. The BACK-OFF JSpA parent trial is sponsored by Patient-Centered Outcomes Research Institute, also known as PCORI. With their partnership, we hope to answer the following questions. Can TNFi be stopped or tapered? What are the risks and time it takes to flare with each treatment strategy? How do patient-reported outcomes differ between the 3 treatment arms? If children flare, how easy and/or difficult is it to recapture disease? The National Institutes of Health, National Institutes of Arthritis and Musculoskeletal Skin Diseases is funding a sub-study of the trial. With their partnership, we'll be able to answer the following questions. Are there serologic markers that can help us risk stratify who will do well stopping or tapering therapy versus who is likely to flare? In those with a history of axial arthritis, roughly 20% of spondyloarthritis, does subclinical information around the sacroiliac joint at time of de-escalation predict subsequent flare? The Spondylitis Association of America is partnering with the BACK-OFF JSpA trial to help answer if there are differences in the development of anti-drug antibodies associated with different TNFi de-escalation strategies, as well as identifying the role of MRI in predicting when flare symptoms reoccur for those with axial arthritis. Both adult and pediatric rheumatologists have seen that prolonged use of TNFi is associated with the development of anti-drug antibodies. Once developed, patients no longer receive therapeutic medication levels and often require increased dosage of TNFi or must switch to a new biologic altogether. It is not known if prolonged intervals of TNFi dosing or lowering the dose of TNFi has an impact on immunogenicity. Drug levels and anti-drug antibodies are not routinely checked at standard practice and are not required at the time of drug de-escalation or when withdrawal is considered. The BACK-OFF JSpA trial is the perfect opportunity to study this question given the study's randomized design. Rheumatologists have seen that the presence of axial symptoms at times does not predict the presence of active sacroiliitis or axial disease on MRI in children with spondy. Pain is sometimes mechanical or secondary to their disease. The accuracy when it comes to predicting sacroiliitis at the time of reoccurring symptoms in patients with prolonged disease remission is unknown. As such, pediatric rheumatologists are not sure whether imaging should be done as part of the potential flare evaluation. In some states, insurance companies will deny covering the cost of confirmatory MRIs when it patients are reporting doing relatively well. We hope that the results of this SAA-funded substudy will provide us with the impetus to get confirmatory MRIs prior to medication de-escalation covered by insurance companies across the country and implementing this into standard practice. On the far right-hand side of this presentation, you can see the trial's progress to date. In the top right figure, you will find the trial's biospecimen participation data. As of now, 48 participants are enrolled in the parent trial, all of whom are eligible for the blood draw. 13 of those were randomly assigned to Arm 1, fixed standard dosing. 10 of those randomly assigned to Arm 2, fixed longer dosing interval. 9 of those randomized to Arm 3, stop TNFI. The overall goal of this sub-study is to have 160 participants opt into the biospecimen collection. Thus far, we're making steady progress and have met 20% of this goal. In the bottom right figure, you will find the trial's MRI participation statistics. As of now, 48 patients are enrolled in the parent trial, 25 of whom were eligible for the MRI portion of the trial. 19 participants, or 73%, have participated in the optional MRI. 5 of those were randomly assigned to Arm 1, fixed standard dosing. 7 of those were assigned to Arm 2, fixed longer dosing interval, and 7 of those were assigned to Arm 3, stop TNFI. The overall goal of this sub-study is to have 50 participants opt into the MRI portion of the trial. Thus far, we are making steady progress and have met 38% of this goal, which is exceeding our projection at this time based on the parent trial enrollment. Enrollment is nearly a quarter of the way complete, as the study will conclude once 198 subjects have been enrolled. To conclude, we would like to thank our parent trial, which is supported through a PCORI Project Program Award, and the Spondylitis Association of America, who is funding and helping us determine the differences in antibody drug development and the role of MRI in predicting flare across these 3 treatment strategies in the BACK-OFF JSpA trial. Thank you.